Good evening, everyone, and welcome to the ins and outs of telehealth. I'm Dr. Serena Bumpus, the Director of Practice for the Texas Nurses Association, and will be your moderator for tonight's presentation. Tonight, I have the honor of introducing our featured presenter to you, Becky Bounds. Becky is the Program Manager for TexLaw Telehealth Resource Center, a division of the Institute for Rural and Community Health at the Texas Tech University Health Science Center. Becky earned her master's in nursing with the Texas Tech University School of Nursing. In addition to clinical nursing experience in multiple settings, Becky has 18 years of experience in ambulatory healthcare, quality, compliance, and informatics, and is now dedicated to advancing telehealth, particularly in rural and underserved areas. She holds certifications in informatics and healthcare quality. Before I turn the presentation over to Becky tonight, I want to make sure all of you are aware that you will have the opportunity at the end of her presentation to ask questions. Please make sure you're using the question and chat box to enter your questions in throughout the presentation. And now I will turn things over to Becky.
Hello. Can everyone hear me okay?
Yes.
Okay. Just a minute. Okay. I'm really pleased to be here today to present about telemedicine and telehealth to you. We just don't have near enough involvement by nursing, for one thing, and it's just the environment is just crazy with COVID-19. It has really accelerated telehealth like we could not have anticipated. So our purpose today is to bridge gaps, and those knowledge gaps about what telehealth is and what's going on in that environment, and the impact on nursing practice. Just a little bit about the Telehealth Resource Center. We are funded by HRSA, federally funded by HRSA, with the Institute for Rural and Community Health at Texas Tech University Health Sciences Center. We serve all of Texas and Louisiana. We partner with the Louisiana Department of Health to form the Telehealth Resource Center, and they provide us support in Louisiana. And the rest of this small print is the disclaimer for HRSA. So we exist to provide technical assistance, outreach, and education to advance telehealth, particularly in rural and underserved areas. So the fact that I work for rural and community health and that our focus is on rural and underserved areas, that does influence my perspective, as you will see. The TexLaw Telehealth Resource Center is one of 12 regional telehealth resource centers and 2 national. We form the National Consortium of Telehealth Resource Centers. What that means is we draw on expertise across the country because we talk every day. The regional centers serve every state and some territories in the Pacific Basin. We have 2 national centers, the Center for Connected Health Policy, keeps track of the policies federally and from state to state, and they do vary a lot from state to state. And then the Telehealth Technology Assessment Center, or TTAC, is our National Center for Technology, and they have a wealth of information and resources related to the technology, the connectivity, the equipment, platforms, that kind of thing. So we have a lot of challenges currently in healthcare, and consider these next few slides sort of the needs assessment. There are many challenges, and especially in rural and underserved areas. Difficulty recruiting physicians and providers, geographic isolation, and diminishing community economics as some of the younger people leave the rural areas, and numerous health inequities. What we find in the rural areas is consider that the rural population in the United States is almost 25% of the population, somewhere between 20 and 25% of the population. But we have 10% of practicing physicians in rural, only 10% in rural areas. There are issues with transportation, long distances to travel to see a provider. We know that, and some of it surprised me, but we know that there is more heart disease, more diabetes, more major depression, and higher suicide rates in the rural areas. So we really need to ramp up some access to care is one of the issues. So I wanted to show you the sort of the picture on the left, are this map on the left are health professional shortage areas for primary care. Anything with the color is all or in part a health professional shortage area. The map on the right shows the rural counties in Texas, everything in green. And I know that's kind of close to the yellow color, but everything in green is a rural county. So while it's not exactly the same, we can see some correlation here. On this next slide, this map is the health professional shortage areas for mental health, and you can see it's a much bleaker picture. Everything, again, in color is either the whole county or partial county or population group that's a health professional shortage area, and again, compared to the rural counties. For this next slide, I switched these over. The first map is the rural counties, and the one on the right is 2020 health outcomes. And this is from the Robert Wood Johnson Foundation and University of Wisconsin. The darker colors represent worse health outcomes. And this is based on air and water quality. Access to care is a big one. And then chronic conditions and mortality rates. So I'm going to talk a little bit about the basics of telehealth. We'll talk about opportunities and challenges, the picture during COVID-19, and then a little bit about nursing roles in telehealth. So telemedicine, there are those that see telemedicine almost as another specialty, but it's not. It's just a tool. It's clinical care from a distance. Anytime the provider is somewhere, the patient is another place, and you're using telecommunication technology to make that connection with that patient, that's telemedicine or telehealth. And we can provide, of course, primary care, specialty care, intensive care, emergency departments, and we've seen telehealth engaged in a lot of other areas, especially during the public health emergency. So what is the difference between telehealth and telemedicine? We frequently use those terms interchangeably, but telemedicine is a subset of telehealth. Telemedicine is generally a physician or a provider practicing under the supervision of a physician, which includes nurse practitioners and PAs. Telehealth includes consumer education, public health, other ancillary and complementary services. If we have a nurse educator, let's say, that's known as telehealth. If it's a clinical social worker providing services, that's considered telehealth. Here are some types of telemedicine, and this is not an exhaustive list, it's just an example, but what we usually think of as telemedicine is live audio and video, and there's a list of some specialties that may use telehealth, but there's a lot of other areas. Then storing forward is another type of telemedicine where there may be a photo or picture taken of, let's say, a skin lesion sent to the physician or the provider and interpreted and sent back. We've done this forever with radiology, but then it's an odd thing because CMS or Medicare doesn't consider, they don't pay for storing forward, but they do pay for teleradiology because they don't define it as telemedicine. Remote patient monitoring is generally chronic conditions and treating a patient in their home. An example would be a patient with congestive heart failure, has equipment to monitor pulse, blood pressure, weight, let's say, and that information feed to physician or provider's office, and parameters are set, and hopefully we can intervene, maybe change medicine, or change some of the care to avoid a rehospitalization or hospital or emergency department visit. So there are a lot of opportunities and challenges. Telemedicine can shrink those long distances in rural and underserved areas. And we know that there's a lot of underserved areas in urban situations as well. It can bring care to special populations. School-based telehealth is a big thing across the country. I don't know if you're aware, but Children's Health in Dallas has, I don't know that it's but one of the largest school-based telehealth networks in the country. Correctional telehealth, and I'm not sure if you're aware of this, but the Texas Department of Criminal Justice contracts with Texas Tech to provide the correctional telemedicine in the west side of the state, and contracts with UT Health to provide the correctional telehealth on the east side of the state. It does save the state of Texas an enormous amount of money, and there is that safety issue too. Anytime we don't have to take a prisoner out of the jail and engage maybe 2 guards, maybe shackled, there may be a safety issue for the general public. Certainly we have huge needs for mental health. Sometimes telehealth can work better. Sometimes that can help remove some of the stigma that may be associated with telehealth that we're trying to get away from. And then provide services during public health emergencies. So we know about COVID-19. We know this is a big thing, but and we've got hurricanes coming right now. But during Hurricane Harvey, that's another place where telehealth kind of was used extensively. In fact, we had lists of telehealth providers that were willing to provide telemedicine and telehealth services for free for victims of Hurricane Harvey. So we'll likely see something similar coming up. Some of the challenges and barriers, these are the kinds of questions that I get through the Telehealth Resource Center. What is the policy? What can you do via telehealth? And what can you get paid to do? And those policy and payment for telehealth are really complex. And that's why the Telehealth Resource Centers, one of the reasons they exist. Provider buy-in can be an issue. There are organizations that will try to start a telehealth program and then force the providers into that mold without engaging them in the beginning to implement the program, and it really never works out very well. There are still areas where there's insufficient broadband and connectivity for telehealth. And then there's technology choices in the cost of technology. I get a lot of questions about what's the best platform to use. Can you recommend one, which we don't endorse any, but what platform, what equipment, a telemedicine cart, full telemedicine cart, if you need it on the patient end, if you needed stethoscope, an exam camera, an otoscope, or any of those peripheral devices, that cart that supports those peripherals can be upwards to $35,000 to $40,000. But we are seeing companies get away from the big cart and the expense of the big cart, and there are other options with cloud-based solutions. Regarding telehealth policy, I'll just run down the list. Here's some of the policy concerns, but I'll run down the list a little bit. For licensing, in general, you must be licensed where the patient is. If you are in Texas and the patient's in Louisiana, you need to be licensed there. There are some flexibilities with those rules during the public health emergency, and I'll talk about those in just a minute. But nurses definitely have a little bit of a better position with the licensing with the nurse compact, because the physician's compact or medical compact is not really functional in the way that nursing is. Informed consent, many states, a great deal of the states explicitly require telemedicine consent, as Texas does and Louisiana does. Credentialing and privileging, that's an issue if you want to provide telehealth long distance into a hospital, let's say a critical access hospital in the middle of nowhere. You need to be credentialed and privileged in that location in that hospital. There are ways to do this by proxy to streamline the process, where the small hospital can use the credentials and privileges of a larger hospital and write that into their policy. This doesn't apply for ambulatory care. HIPAA is always an issue. HIPAA is more about what we do, but in the case of telehealth, the security part is built into the technology. Online prescribing is restricted in many cases in Texas, and up until COVID-19, you were prohibited from prescribing controlled substances for chronic pain management via telehealth, or any drug that would cause an abortion. There are a lot of flexibilities again during COVID-19. And then as far as malpractice insurance, if you're looking at malpractice insurance, I would just make sure that the provider explicitly states that telehealth is covered. And this is some state telehealth laws at a glance, just to show you how complex and different it can be. And it really is sort of craziness, but 49 states and DC have a definition for telehealth, telemedicine, or both. 19 states reimburse for service to the home. That has changed now. That COVID-19 has provided greater disruption to the telehealth environment than we could ever have anticipated. 40 states have acted private payer reimbursement laws, or we call them parity law. 38 states in DC require consent, and licensure across state lines is an ongoing issue. Regarding reimbursement or payment for telehealth, it's usually the #1 question that I get. How do I bill it? Can I get reimbursed for it? So this gives you a general overview of the criteria for payment. Medicare cares about, and this is pre-COVID-19, the patient setting, the technology used. They prescribe the geography of the patient, and by that I mean health professional shortage area that's also in a rural census tract. You can see how restrictive that really has been. And they prescribe certain providers and certain service types. By that I mean there's a list of providers types that they will reimburse, and the service types, there's a specific list of codes that they will cover. For Medicaid, patient setting, the technology, most Medicaid, I don't believe cares about the health professional shortage area. and whether the patient is rural. In Texas and Louisiana, Medicaid covers and doesn't require that. And then for commercial, there's parity law. Parity law essentially says if telehealth is a covered service, you should not deny it because it was provided in this way. And during COVID-19, there's a additional pressure federally and in the states directing the commercial payers to cover telehealth the same as in-person visits. And they may follow Medicare or Medicaid policy, and we may not know what their policy is. Texas has done quite a bit to be telehealth friendly and to require commercial payers to post their telehealth payment policies. And there are some exceptions to whether the commercial payers have to pay or not. If it's what's called an ERISA plan or the self-funded, partially self-funded plans by employers, are not under the jurisdiction of the Texas Department of Insurance, and they can carve out telehealth. We see fewer of them do so, but there are still some that do. So this is the basic billing model. Again, for Medicare, they said patient had to be in a health professional shortage area that's also rural. Patient had to come into a healthcare facility for care and not in it, with few exceptions, could not receive care in their home. There's a CPT code range, which there still is, and a list of eligible providers that they will cover and none others. So let's see what's going on with the public health emergency. It's just exploded. Part of the flexibilities during the public health emergency, once it was declared, they wanted to reduce administrative burden for healthcare providers, increase telehealth because it's made for social distancing because we're providing that clinical care at a distance. So on March 15th, the Secretary of HHS waived certain penalties and sanctions under HIPAA. In fact, they told providers that temporarily during the public health emergency, you can use FaceTime or Skype, even though it's not secure, because they wanted providers to be able to get access to their patients and to telehealth quickly. Going forward, we would say that that's not best practice, certainly. And then the CARES Act was signed into law on March 27th. So here's what some of those flexibilities did. I said that Medicare restricted the patient location, so they removed those geographic restrictions. The patient's home is now an allowable site. Previous to this, there were a couple of areas where the patient could receive telehealth services in their home, but only for opioid and substance use disorder, because it was seen as such a crisis that we needed to be a little more flexible about treatment. The modality, before Medicare required real-time live audio and video to qualify as telehealth or telemedicine. But during the public health emergency, they will cover telehealth for live video. There are codes for phone only, which was unheard of before this happened. There are communication-based services that are a little different than our traditional telehealth, and they're virtual check-ins and e-visits. And I have on the next slide how Medicare is defining those. That specific provider list that they had before, which was physician, nurse practitioner, PA, social worker, psychologist, nutrition professionals. Now all healthcare professionals that may bill Medicare can bill for telehealth during this time. They added a number of codes. We went from 115, I think, to 240 codes that they will cover during the public health emergency. And then reimbursement federally and in Texas, they directed commercial payers to pay telehealth the same as in person. And so that was a huge thing. And so what started then, as soon as this stuff came out, is the calls started coming all day long, and for people that had never considered telehealth before and wanted to get started right now. So the telehealth resource centers are the place to go to figure out where the resources are to help you get started. So what do we do with these policies now? The director of CMS, Seema Verma, I believe her name is, she has said, I think the genie's out of the bottle. We can't go back to the restrictive policies that we did have. So we are looking for some big changes. And some of the flexibilities during COVID-19 to be allowed beyond the public health emergency. The physician fee schedule has just come out, and at the very least, for some of the codes, they're trying to add some of the new codes onto the list. Some of the codes will be in place until the end of the year when the public health emergency ends, whether that's this year or the next. Here are the types of telehealth services that are defined during the public health emergency. And this is really different. The telehealth visit was what Medicare would cover in the past, and it needed to be real-time audio and video using telecommunication systems. You could see, but now you can see new and established patients. In Texas, yes, you can see new or established patients. They added the virtual check-in, which is a brief check-in, 5 or 10 minutes. It can be by phone. The patient can send an image and get a response back after that. It's for new or established patients, and there are different codes to use to build a virtual check-in. It does pay less than the telehealth visit. E-visit is non-face-to-face. It may be communication through a patient portal. And then there are some phone-only codes. They issued some telephone-only evaluation and management codes that can be used. And these are to be used when the patient does not have the capability of video or wishes not to use it. It does pay a lot less than a regular telehealth visit. I want to talk a little bit about nursing roles, because I just think how fortunate and how blessed are we that we are in a profession that gives us so much opportunity and flexibility. So I often see in large health systems, the director of virtual care or telemedicine, or however they define that position, is very frequently an RN. There is value, like there is in the other side of Informatics Nursing, that there's value in that clinical perspective when we're looking at implementing telehealth. So certainly there's advanced practice nursing that can use telehealth for patient care. School-based telehealth I mentioned. If in school-based telehealth, if there is a school nurse, they can help facilitate that visit on the patient end, or anyone else can that's trained to do so. When we find that when a child in school is sick and the parents are called to come get the child and to take them to see their physician or provider, that's generally 3.5 hours off of work for the parent, and schools are paid by attendance. So if the child goes home, then that's potentially missed revenue for the school. Multidisciplinary chronic care management, certainly nursing fits in there in many different ways. If you are involved in project and program management, if you're an educator, if you're a clinical nurse leader, you have a role in telehealth. And then Informatics Nursing. My certification is Informatics Nursing with ANCC. And we have heard this about Informatics Nursing in the EHR, electronic health record world. That nurses have become the translators between the technical and the clinical communities. And with telehealth, we're in that position again. So if you're involved in quality improvement, which I've been, data aggregation and analysis, compliance, if you plan to be a consultant, provide education and professional development, policy development and advocacy, or research and evaluation. There are so many nursing roles in informatics. I believe that informatics nursing was not, or to me, and this is I guess a personal disclaimer, that informatics nursing was not very well defined until we started the move to electronic health records, and then have seen telehealth advance, because telehealth does fit into that category as well. So these are our references. A lot of the information that you can find from Rural Information Hub, if you're interested in rural and those underserved areas and more information about that, this including social determinants of health, that there's really good information there. Here's the CMS Medicare telemedicine fact sheet, which is the flexibilities and new rules since COVID-19. Then there's HRSA health professional shortage areas. There are maps. There's a lot of good information there. And then the county health rankings and roadmaps, you can find the link here. So I'm going to talk about resources, and I mentioned these, but here's how you can access those. The National Consortium of Telehealth Resource Centers. Here's our website. You can find a map that will lead you to any one of the telehealth resource centers by clicking on the state. The National Center for Policy, or the Center for Connected Health Policy, they have a wealth of information and working very hard to keep track of all the new legislation coming out and pending during this crazy time. And then TEXLA, TRC, that's us, and here's our website. We do have ongoing virtual office hours that will be once a month starting next week. I also regularly have webinars for Telemedicine 101 for those that want to get started for telehealth, to help them navigate that. And then the American Telemedicine Association. Here is my contact information, and I'll be glad to answer any questions you may have. If I don't know the answer, I will find it.
Thank you, Becky. That's a great presentation, and we appreciate you sharing your knowledge with us. We do have a few questions that are coming in. For those of you in the audience, please use the question and chat box to type your questions in, and we'll try to get to as many of them as we can. The first question is, A member of the audience would like for you to repeat where they can find the information on rural areas and social determinants of health.
Okay, I'm going to go back a couple of slides so you can see that. The Rural Health Information Hub. There's also, you've heard of Healthy People 2020. Well, there's also a publication that's Rural Healthy People, and I would look that up. There's great information there.
And the next question asks, are there nurses in the field in the low-income rural areas that can also help patients with telemedicine due to the limited use of smartphones and computers in those areas? How can we get telemedicine to the patients that truly are at high risk outside of our urban patients? And they also commented that this was a great presentation.
Well, thank you. I'll have to go back. I think you're asking how we get telehealth to those rural areas that still don't have good connectivity and internet. Is that what you're asking?
Yes, that's what she's asking.
Okay. So here are some options. We have to think outside the box just a little bit, but most people do have sufficient broadband and or can use a hotspot or something. But there are some areas here. Here's an example. I had a call from Fort Davis, which is Southwest Texas, and they are really a shortage area. They have nothing. It's at least an hour by ambulance to get to an emergency department. So I had a call from the library because they have connectivity. And so if a community can consider where they may have connectivity and think about using some different locations and organizations to make it happen.
And then there are several people who are interested in contacting you to potentially gain access to your slides. So you may have some people emailing you for additional information and permission to do that.
Absolutely.
The next question, I would like to know your opinion on a new adult gero primary care nurse practitioner. I'm trying to see. A vetted 11-year nurse, well-versed in case management and electronic healthcare record, home health, and long-term care, jumping into telemedicine as their first job. So this is a brand new adult gero primary care nurse practitioner who's had 11 years as a nurse in case management EHR and would like to jump into telemedicine as an NP.
What I would suggest that you contact me, and then, as I said, on our website, there's numerous resources. Telemedicine 101 is that getting started presentation, and I would start there. Think about what your service model would be. What patients are you trying to reach? Would you like to reach them? And then contact me, and what we figure out is, will policy allow you to do that? Can you get paid to do that? And so that can help direct which way you go from there, and then we can give you some steps to go from there.
And Becky, would you move your slide back to show your contact information? There were a few who missed that in the audience. All right.
So one more. Okay, so here is my email. We also have a Texla email, texlatrc@ttuhsc.edu. If you don't get this down or lose this, you can go to texlatrc.org, and there's a button that says contact us, and it will come through and email me. So numerous ways to get me.
Next question asks, do you have any quick tips or suggestions on how to effectively perform an assessment via telehealth?
I do have some resources, and there's been a lot of discussion about that. What kind of physical exam can you do, and what can you not do? I would think back about your physical assessment and how much of it is visual. How much can you get the patient to assist you with? Can the patient provide you with pulse or blood pressure, for example? But I do have some resource material that's suggested what you can document for an exam for a telehealth visit. But there is equipment. There's all kinds of cameras, ultrasound, EKGs that can plug into telehealth equipment, either the telemedicine cart or even in a USB of a computer. We understand that most patients in their home are not going to have all those capabilities, but there are a number of add-ons for iPhones or smartphones that where the patient can assist you with that exam.
And the next question asks, how many charter states are there for nurse practitioners doing telehealth? And are there any states that are surrounding Texas?
I'm sorry, like when you say charter states.
I think she means compact states.
Compact states? I would have to look it up at the state board website, because I can't tell you off the top of my head which states that are a part of the compact. Even though my license is part of the compact, I couldn't tell you right now. But I would be glad to find that information for you or give you a resource where to find it. But I would start with the Board of Nursing, Texas Board of Nursing.
And for nurse practitioners, Texas is not part of the compact license for NPs. They are for registered nurses, but nurse practitioners, as of right now, they are not. So that's if that's what this question is asking, then that would be the answer.
Okay.
I don't see any other questions right now from the audience. I'll give a few more minutes to see if anybody wants to populate anything. Otherwise, we will, oh, here's one more that just popped up. Do you think telehealth is the future? And do you think it will go back to the way it was before COVID?
I really don't. And there are, we've seen what telehealth can do. We knew what was possible, and this showed everyone what was possible. It's the best way to social distance and provide care to patients. I don't see it going back like it was. There are numerous professional associations and groups that are lobbying, writing Congress now to make sure that some of these flexibilities are included in future policy. But I don't see it going back to what it was.
Well, Becky, you've received numerous comments here in the questions and chats. Just everyone thanking you for your presentation and the value that they found in the information that you shared. So thank you very much for being here with us tonight and for sharing your knowledge with us. And with that said, I don't see any other questions from the audience. Again, a lot of thank yous. And so with that, I think we are able to end our presentation. Any parting words from you, Becky, before we go?
Now, I do think it's the future. I think the biggest change here was to allow telehealth in a patient's home consistently, and I think we'll see a lot more of that. With the remote patient monitoring, that's a different thing. That's a different kind of monitoring in a patient's home. By the way, home health care does usually set up that equipment, train the patient on how to use that equipment to monitor their chronic condition.
All right. Well, I thank all of you in the audience for joining us tonight. You had some great questions, and we appreciate your participation. And with that, we bid you all a really great night, and be well and stay safe out there. Thank you.
Thank you.